Good morning, and thank you for joining us for our latest Ontario Medical Association briefing on important healthcare issues in the news. My name is Dr. Andrew Park, and I'm the president of the OMA, which represents over 43,000 physicians across the province. Today, we're here to talk about the crisis in family medicine and our solutions for fixing it. 2 years ago, the OMA released our roadmap for the future called the Prescription for Ontario Doctors' 5-Point Plan for Better Healthcare. This document contains 87 recommendations for reversing the decline in Ontario's healthcare system and making the province a national and global leader in healthcare. We're pleased that the government has taken action on 51 of those recommendations, but there is still much to do. The OMA has identified 3 urgent priorities that require immediate attention. Number 1, fixing the crisis in primary care. Number 2, addressing the growing administrative burden on physicians. And number 3, increasing community capacity and tackling hospital overcrowding. We have solutions to all 3 problems, which we will bring to Queen's Park on Monday, where over 100 physicians are meeting with over 50 MPPs and cabinet ministers. Regarding the crisis in family medicine, we have identified the top 2 solutions the Ontario government can and should implement now. First, every Ontarian should have access to a family doctor and a well-coordinated healthcare team supporting them when and where they need it. Second, we need a northern and rural workforce strategy that includes a pathway for licensing more internationally educated physicians. We'll be holding a separate media briefing on the unique healthcare challenges in Northern Ontario on November 1st, and I hope you can join us. Fixing the crisis in primary care will not happen overnight, but maintaining the status quo cannot continue. The strains on the healthcare system have ballooned over decades, and it will take time to fix these issues, but we must start somewhere, and we must start now. Only 30% of family doctors practice with government-funded, team-based supports, meaning that more than 2/3 do not. This means that too many Ontarians lack preventative primary care in a team-based environment, which can lead to difficulty accessing specialists and diagnostic care. This creates further issues in the system, such as emergency department overcrowding and hallway medicine in hospitals. The OMA is calling on the provincial government to give all family doctors and their patients access to primary care teams, which would include nurses, administrators, and other healthcare workers. These primary care health teams should be tailored to meet the needs of patients in different communities and should include at least a physician, nurse, administrator, and at least 2 other interprofessional care providers, such as social worker, registered dietitian, a nurse practitioner, physiotherapist, pharmacist, specialists, and mental health professionals and/or outreach workers. Each member of a team has a unique set of skills that complement one another rather than compete with one another. Let's allow doctors to be doctors, nurses to be nurses, and have other health professions focus on what they do best for patients. Together, we can ensure that patients are getting the best care possible. Furthermore, the OMA is also calling for a workforce planning framework to understand how many physicians are needed in Ontario now and in the future, what kind of physicians, and where they are needed. Our colleagues from the Ontario College of Family Physicians and the Inspire Primary Healthcare Research Collaborative are going to release new data today showing a drop in the number of doctors choosing to practice comprehensive family medicine. I'd now like to introduce our expert panel members. Dr. David Barber is a chair of the OMA section of General and Family Practice. He practices family medicine in Kingston. Dr. Kamila Premji, a family physician in Ottawa, is part of the Inspire Primary Healthcare Research Collaborative. And lastly, Dr. Mekalai Kumanan, a family doctor in Cambridge, who is a president of the Ontario College of Family Physicians. I'm going to hand things over now to Dr. Barber to tell us about the benefits of team-based care for patients and physicians.
Great, thanks, Dr. Park. So we definitely are in a crisis, crisis in family medicine in Ontario. I think the important thing to realize is that, the crisis is the crisis for patients, right? And the reason for this is when a patient doesn't have a family doctor, they essentially have no access to our healthcare system. Their only entry in is through the emergency room, and further to that, they won't be getting screening, and it's a terrible situation for those 2.5 million patients who can't get access. It's not fair. You're creating an inequitable system. So, we need to fix this. We need to fix this as quickly as possible, because, without all the screenings that need to happen, it's just going to add increased burden, onto the system later. And we can see this happening in the emerge rooms across Ontario at this point in time. The crisis is also for family medicine. The reality is that family doctors are so stressed right now. They even the idea of having to say no to patients when they are asking if they can take them on, as a patient, and to the lack of funding and a lack of team-based care that could help with a lot of problems is really quite stressful. And it's compounding the situation, in the sense that the new grads, the medical students, see what's happening in primary care, and they're not choosing primary care, as they're not choosing to be a family doctor because they see that it is not a good environment to practice in, and they can't help the patients, which is really what we all want to do. So the question is, so what can we do? Well, there's a lot of things we can do. The system isn't working well. There's a lot of bureaucracy. I mean, that's something that can be fixed quickly. There are a lot of artificial constraints that exist right now. And the other one is the team-based care. And the team-based care is really important in the sense that, the reality is that most family doctors, the majority, work on their own. I mean, they might have maybe a nurse, they might have a receptionist, but really they're on their own. And so I was talking to a family doctor last night who's done a lot of studies, and she minute by minute took account of her day, and 70% was spent doing paperwork and looking at labs, and 30% was face-to-face with patients. And so that's not what we should be doing. And if we can fix that, then a patient, the family doctors can see more patients and help to alleviate the issue with unattached patients in Ontario. So if we can surround a family doctor with a team of health professionals, that will deburden the family doctor during the day. As an example, there's a lot of musculoskeletal problems that people come in with, let's say low back pain. There's no reason why that patient can't be first seen by a physiotherapist. Physiotherapists are extraordinarily well trained, and that they can see the physiotherapist first, and allow the family doctor to see more patients in general. And that the team also includes, as Dr. Park said, social workers, nurse practitioner, nurses. If we change the system a bit, we can make family doctors more efficient, and we can take up the slack of those, some of the 2.5 million patients over time. And it will lead, because doctors will be doing what doctors should be doing, it'll make life and work more enjoyable. And we can make family medicine attractive to medical students once again. So I'll leave it at that, Dr. Park, and hand it back to you. Thanks very much.
Thank you, Dr. Barber. Now I'd like to hand things over to Dr. Kamila Premji, who will tell us about new data showing fewer doctors are choosing to practice comprehensive family medicine.
Thank you, Dr. Park. So our research team at Inspire PHC has been examining trends in the type of work that family doctors in Ontario are doing. Not all family doctors are practicing what we call comprehensive family medicine, which is the type of cradle-to-grave primary care that most people think of when they think about having a family doctor. Comprehensive family physicians serve a defined group of patients on a longitudinal basis, and they deliver a broad range of primary care services, which includes acute care, chronic disease care, preventive care, and they also help coordinate and navigate care for their patients across different parts of the healthcare system. This is the kind of primary care that is rightly the foundation of our healthcare system, because it results in improved health equity, improved health outcomes, and reduced health system costs. But what we're seeing in our analyses is a downward trend in the practice of comprehensive family medicine. In 2008, 77% of family doctors in Ontario were spending the majority of their times providing this type of care. But as of 2022, only 65% are doing so. Now, due to the pandemic and resultant changes in the types of visits family physicians were providing, particularly in the early phase of the pandemic, we note that the proportion of family doctors practicing comprehensive family medicine may be a slight underestimate, but we believe this to be the most accurate number possible, and it follows a pattern of a steady decline we have seen since 2008. Instead of comprehensive family medicine, we are seeing that an increasing proportion of family doctors are spending their time on what we call focused practices of care. These are more narrow types of work, such as palliative care and sports medicine. They're important areas of the healthcare system as well, but what it means for workforce planning is that simple head counts of family doctors significantly underestimate our actual primary care workforce supply. And it also suggests that we need to find ways to support family doctors to choose comprehensive practice. The other interesting pattern we see is one that challenges the common narrative around who's not practicing comprehensive family medicine. The common narrative is that it's mainly new graduates who are choosing not to practice this type of primary care. But actually what we see in our data is that the shift away from comprehensive family medicine is occurring across all physician career stages. This includes mid-career physicians and late career family doctors as well. The theories behind why these shifts are occurring have been mentioned by Dr. Barber and Dr. Park, and these include policy changes that limited entry of family physicians into alternate payment models and interprofessional team settings, the lack of team-based support in general, and the administrative burden that increasingly pulls family doctors away from direct patient care. And these reasons likely also explain the residency matching data from CARMS that shows that family medicine as a first choice discipline among graduating medical students is now at the lowest it's been in 15 years. So I'll leave things there and hand it over back to Dr. Park.
Thank you, Dr. Premji. Now I'd like to hand things over to Dr. Mekalai Kumanan, who is going to talk about some of the solutions to the crisis in primary care.
Thanks, Dr. Park. So Ontarians are faced with an untenable situation. We know that the shortage of family doctors is one of the biggest issues facing our healthcare system today. And already we've heard that there are more than 2 million people across this province who don't have a family doctor. We've also touched on when patients don't have a family doctor, it means that things like cancers can go undetected. People may miss vaccines, and we know more people may turn to the emergency room, often because they don't have anywhere else to go. Every day, I know I've been hearing in the news, as well as from colleagues and neighbors, about someone who's waited in an emergency room for hours before they're seen. And we know that many of these people don't have a family physician, and that's why they're there. In my office, we regularly hear requests from patients looking for a family doctor. And unfortunately, we're over capacity and are not able to take on more patients. And I can tell you this situation is not unique to my clinic. It's happening in communities across Ontario. So to address this crisis, we need to start by ensuring family doctors have the supports that they require to keep doing the important work that we do for our patients. Otherwise, as we've heard, we know that we will continue to lose family physicians, and we'll see fewer medical students choose this profession, ultimately leaving more patients in this province without the care that they need. Now, family doctors have solutions, and we are ready to work with the Ontario government to make this happen. I would like to start by echoing what my colleagues have shared about the need for family physicians and our patients to have access to team-based care. I believe a lack of team support is in part what has led us to the crisis that we're currently in. And the OCFP has been advocating for all family physicians to be supported by teams. We know the Ontario government recently made an investment into 18 new teams, but this is not enough, and much more needs to be done. Adding to this crisis as well is the administrative burden that family physicians face. The Ontario College of Family Physicians conducted a survey earlier this year that showed that family doctors spend more than 19 hours a week on administrative tasks. Examples of this include writing unnecessary sick notes for patients and filling out lengthy insurance forms that often are different for each insurance company. So the OCFP is advocating to the provincial government to work with family doctors to eliminate unnecessary red tape. As an example, we're calling on Ontario to pass legislation prohibiting employers from requiring a doctor's note for occasional absences, as has already been done in Nova Scotia. We also need to see a change to forms. Family doctors spend a lot of time filling out lengthy disability forms that are not standardized and making referrals for services like massage therapy. We know that these tasks take time away from the time that we have to see our patients, and we know many of these tasks are, in fact, unnecessary. So cutting these tasks out will ultimately free up more time for family doctors to spend with our patients. In order to address this situation, we need to start with improving the profession and making sure that family physicians have the supports that we need to continue practicing family medicine. And by eliminating some of these system-wide challenges, family doctors can spend time doing what's needed most, which is spending quality time with our patients. I believe it's not too late to change course and take immediate steps to cut the red tape and reduce the administrative burden that we face so that our patients can get the best care possible. But we do need action now.
You're on mute, Dr. Park.
Thank you. Vestige of the pandemic here. Thank you to our panelists for sharing your expertise. We are now going to open up our Q&A session. The OMA's Emily English will moderate this portion of today's briefing. You can put your questions in Q&A chat. And as always, if we don't get to your questions, the media team will follow up with you. You can also email media@oma.org with requests for interviews or information. And we will have a recording of this session available later this afternoon. Emily, over to you.
Thank you very much, Dr. Park, and thank you to all our panelists. The first question is for Dr. Barber. What impact does not having a family doctor have on a patient?
Well, it's a significant impact. I mean, the way that, I mean, like I said, the way that our system in Canada is designed is, you know, the family doctor is the gatekeeper to the system, and when there's no gatekeeper, there's no way to get into the system. So the tragic thing right now, you know, in Kingston, we lost 5 family doctors in the last 6 months, and so 7,000 patients don't have a family doctor. So, and these are, you know, a lot of these patients are sick. They have diabetes, they have high blood pressure, they need medications refilled. So it's terrible, and so those patients, they don't have anybody to see to manage those issues, and so it's having a significant impact on their health. Think of all the mental health issues that are not being addressed. And so, you know, I think, you know, for family doctors, there's actually a lot of guilt around this, because we see these patients and they're asking us to help them, but the capacity just isn't there. But I think, you know, unfortunately, you know, the impact of this over time is there's going to be an increased morbidity in that population. There's just, and those patients are going to suffer. It's a terrible, terrible thing. You know, but you know, there are things that we can do quite quickly to help with the situation. Yeah, a lot of sympathy for those patients who don't have a family doctor.
Thank you very much. And Dr. Park, can you tell us more about the impact on the healthcare system overall when patients don't have family doctors?
Yeah, absolutely. So if you look around the world, the systems that get healthcare right are those that focus on primary care, which forms a foundation of healthcare. It's like looking at a problem in terms of upstream versus downstream care, and family medicine, in this case, primary care with family medicine as a backbone of primary care, is the most upstream location, as Dr. Barber has said, in terms of how we think about care at the individual and societal level. I think that what you're hearing repeatedly, even throughout the introduction and through Dr. Barber's first answer, is that healthcare really isn't about cost. It's really about investment, and that investment is really important, both from an individual health level, at screening level, but also from a system standpoint, looking at economic productivity, the ability for individuals to feel healthy to go to work and feel fulfilled to do their job and provide for their families. And this is why in many different elections, the economics, the economy and healthcare are the two most interlinked issues. And this comes up repeatedly. Family medicine, primary care form the backbone of that. And that's why it's so important to our system.
Thank you very much. And we have a question now for Dr. Premji. Dr. Premji, can you tell us how costs can be lessened if we have interprofessional care teams?
Yeah, so we actually have Ontario data to support this. We have a 2017 study that looked at the new models of primary care, including family health teams, and found that the total health system costs for patients attached to primary care within these types of models of care were lower than those who were attached to the traditional fee-for-service type of model of care. And this was despite there being higher primary care costs associated with these newer models. So the primary care costs were higher as expected because you were involving, for example, more health professionals in the care for patients, but the overall total health system costs were lower. And I think that's very important to consider, that primary care is an investment. It's not to be seen as a cost. I think we need to shift away from seeing it as an expense item in a budget and rather an investment into our overall healthcare system and our society at large, as Dr. Park has said. We also have data from the community health centers in Ontario. Community health centers are team-based models of care that tend to serve the most vulnerable populations in our province. And the findings from that research show that they consistently demonstrate better chronic disease management, better patient experience, and better provider and team satisfaction, and fewer emergency room visits than you would expect given the level of complexity of those patients. So those are two Ontario-specific examples of data supporting family health teams.
Thank you very much for that answer. And the next question is for Dr. Kumanan. Don't all doctors have to perform administrative tasks, and aren't some administrative tasks necessary?
Yeah, thank you. So, maybe I'll start by saying in the survey that the Ontario College of Family Physicians conducted earlier this year, we heard from family physicians that they spend over 19 hours a week on administrative work. And in fact, that number makes up about 40% of our time spent doing our work each week, much of which is unnecessary. And I think what's key here is that this volume of administrative work is ultimately impacting our ability to care for patients. We also heard from family doctors, 94% said they were overwhelmed with this administrative burden. And we saw from the same survey that over 60% of family physicians are planning to change how they practice and potentially even leave practice, largely in part because they aren't doing the work that they want to be doing, which is spending time with patients. Now, I will say, I think we all know that some administrative work will always be necessary, particularly when we think about the role of a family physician, advocating for our patients, helping our patients to navigate the healthcare system. But I think we can all agree that 19 hours a week on administrative work is far too much. So the OCFP has been advocating for some of these administrative tasks to be taken off our plate altogether. And we can think about things like sick notes for employers, which take up our time but should not be required. And I'll just add as well that we know that if we can build in those team-based supports, and if family physicians are able to work in the context of a team of providers supporting our patients, that will then allow us as well to sort of help manage that workload, and we can then focus on spending time with our patients as family physicians.
Thank you very much. And another question for Dr. Barber. How would having a team of healthcare workers help a family physician in their practice? What tasks can be done by other members of the team instead of a doctor?
So, the way things are said, there's many areas. A lot of the, as a start, a lot of the forms, could be filled out by other allied health professionals. Even reviewing the labs that come in, that could be done by somebody else. Right now, the family doctor is forced just by the way the system is set up, forced to see diabetic patients 4 times a year. A nurse practitioner can't see those patients, nor a nurse. And so that probably represents, in some practices, that's 10% of visits managing diabetics. And it just doesn't make any sense at all. So, I know that's not administrative, but, a change where a nurse practitioner could see those diabetic patients would have a huge impact on we're doing. So I think forms and labs, sick notes, there are many things that could be shared. The problem right now is that the way the system is designed, it's not possible to do that. We need the help from the government to help give us the resources that can allow us to distribute the work and allow us to see more patients and to solve the problem of patients not having family doctors.
Thank you very much. And a question from Kelly Grant with the Globe and Mail. This one's for Dr. Andrew Park. Health ministers are meeting in Prince Edward Island this week. What's the number one thing that you'd like to see come out of that meeting?
In any discussion that we have around healthcare, particularly in the climate that we're in, it really is about access to quality team-based care, particularly at the primary care level. So I think it'd be really key to see a focus on ensuring that every person, and I realize this is a health ministers conference across the country, but from an Ontario focus, and I imagine that the rest of the provinces are the same, has access to a family doctor and a team that can help support their care needs. There's just so much fragmentation around our system right now, and I think a key element of integration is ensuring that everyone is attached to a family team, a family doctor, as well as a team of providers that can help support their needs. So that, again, as I've said, that this is not a cost basis, this is an investment basis, so that we ensure the overall health of our population.
Thank you very much for that answer. And the question now for OCFP President Dr. Kumanan. We have a question from the Medical Post. Reporter Marjo John is asking, how can family doctors adapt to health teams? What do they need to change in terms of mindset or practice in order to work effectively as part of a health team?
Yeah, thank you for that question. I know we've heard a lot about the need for expanded team-based care across our province. I think, I'll start by saying family physicians are collaborators. We are team players. We like to work with other healthcare providers. And in the proportion of family physicians across this province who are working in team-based settings, I think we've seen that often those models are working fairly well, and family physicians are quite happy to be working with other allied health professionals. I think it's important to really think about how we can ultimately sort of increase capacity in primary care. None of us want to be turning away patients when we're asked to take on more patients, knowing that we're facing such a shortage in our province. And I think we know that team-based care is one mechanism that will allow us to take on more patients and better serve our population. So I would say, when we're looking at that shift, every community is going to be different, and we'll want to make sure that those teams are meeting the needs of the population in each community, but certainly family physicians would be on board as well.
Thank you very much. And Dr. Premji, another question for you. For those who aren't familiar with the term, what exactly is comprehensive medicine and why is it important for patients?
Yeah, so comprehensive family medicine or comprehensive primary care is that type of cradle to grave family medicine that people generally think of when they think of what it means to have a family doctor. And it's reflective of 4 core principles of primary care. One is that the family doctor is your first point of contact to access the healthcare system. The family doctor is providing comprehensive care, meaning a broad range of services for acute care, chronic care, preventive care across all age groups and health and social backgrounds. That continuity of care is a key aspect of this. Continuity of care is seeing the patient on a longitudinal basis, again, cradle to grave, And there's ample literature now that has consistently shown that continuity of care is associated with better health outcomes, lowers health system costs, even improved mortality rates. So it is critical to comprehensive primary care. And then coordination, the analogy that the family doctor is the quarterback of your healthcare team and is managing and overseeing all of the care you're receiving and organizing all of the care that you're receiving across the healthcare system. So all of that information is consolidated in one place, and one person has an overview of the entire picture of your health. So this is very important type of care because it has been consistently associated as well with improved health outcomes for patients, reduced health system costs, and improved health equity. So this comprehensiveness piece of family medicine that we are seeing a decline in is especially concerning because we know it has these negative implications for both patients and the healthcare system to see that comprehensiveness eroding.
Thank you very much. And another question for Dr. Park. As OMA President, you regularly meet with physician members. So what are some common issues that you hear specifically from family doctors?
So Dr. Kumanan talked about this, and I'll expand a little bit on it because the key thing is this, is that Ontario's doctors, Ontario's family doctors want to take on more patients. They want to be able to provide care for those 2.2, 2.3 million Ontarians without a family doctor. They're just unable to. And I think that creates a lot of moral injury around wanting to provide that care and being unable to. So it's an extraordinarily draining process. Hearing the amount of work that goes into the administrative burden of being a family physician of 19 hours, that's more than 2 full work days. And either that means that you're not seeing your patients or you're not seeing your family. And that is an extremely stressful environment under which to be practicing. And as Dr. Premji has also alluded to, that's what influences how people make choices around career. And in order to provide care, we have to be provided with the infrastructure and the system to be able to adequately do so. And I hear this repeatedly from my colleagues and from family physicians around the province that they're just not able to do so. And that's why we're suggesting and wanting to work with government around solutions to be able to facilitate this.
Thank you very much. And another question for Dr. Kumanan. So if family doctors are spending 19 hours a week on administrative work, what are some examples of work that could be eliminated?
Yeah, that's a great question. Thank you. And again, I think we know that some administrative work will be necessary as we're supporting our patients. But really, I think none of us want to see family doctors spending 2 full clinical days on administrative work. So I've touched on sick notes. If we could look at eliminating sick notes for temporary absences, that would help. We also know that notes for paramedical services like massage therapy, physiotherapy, really are just, again, adding to that number of hours that we're spending per week on administrative work. So we could eliminate that as well. And I think there are other areas of the administrative tasks that we are carrying out week to week that could just be streamlined a little bit more, not necessarily eliminated. So when we are filling out things like disability forms, insurance forms for our patients, certainly that's going to be a necessary part of what we do, but can we streamline some of that work and maybe standardize those forms? So I'm not having to fill out 3 different forms for a patient who is off work. We could also look at standardizing things like requisitions. So if I'm ordering an x-ray somewhere, can I use the same requisition if my patient wants to go to one location versus another? And then I think, we also hear from family physicians that referrals to other parts of the healthcare system, including specialists, can take up a tremendous amount of time. And I think when we're looking at how we approach referrals in the absence of a centralized referral system, really we're leaving it up to each individual family doctor to kind of have their own personal Rolodex of providers and specialists they can refer to, which is not an effective way to manage referrals and ultimately just means more legwork and administrative work to manage those referrals. So I think there are some broader system pieces that we need to look at to help as we are navigating care for our patients across the system. And then some very specific areas where we could potentially eliminate some tasks to reduce that administrative burden.
you very much for that answer. Another question for Dr. Park. Dr. Park, we've been talking today about primary care teams as a solution. So how can primary care teams also lead to reduced costs?
Yeah, just by a few mechanisms. Number one, as my colleagues have talked about, is an ounce of prevention is worth a pound of intervention. And so understanding that patients who are better cared for are going to cost the system less in the long term, as well as provide some economic productivity back into the system because they're healthy. The evidence from BC suggests that a sick patient without access to a primary care, without access to high quality primary care, can cost up to $30,000 per year versus one with a comprehensive family care model, the same patient costs $12,000. So I think given if you extrapolate that cost to over the 2 million Ontarians without a family doctor, that's a massive windfall, as well as just again, as I said, keeping our patients healthy and able to be productive in their own lives. So it's massive and can't be understated. And while the costs of this are not trivial by any means, these aren't costs. These are investments.
Thank you very much. Another question for Dr. Park. On Monday, you are leading a group of physicians to Queen's Park to meet with government officials about the solutions that we're talking about today, including more investments in primary care teams. So what are you hoping to accomplish on Monday at Queen's Park?
Yeah, this is a really exciting time for the Ontario Medical Association and our members. As I said, over 100 of us are registered, and we will be meeting with MPPs from across the province. This is a real opportunity for us to continue to engage with this government, who has been responsive overall, but largely we do need more resources. We do need more funding into the system that allows us to be able to do this job. We need to be smart about where we allocate those resources. That's really the discussion we're going to be having with our counterparts in government, and ensure that they're hearing this from not just me, but grassroots members who have the lived experience of the frustrations of trying to provide care in a system that hampers their ability to do so.
Thank you very much. Another question for Dr. Kumanan. If the administrative burden was lessened for family doctors, would that result in more patients being seen?
Thank you. I think when we look at the crisis that we're facing right now with more than 2 million patients who don't have a family doctor, we certainly need to look at all of the ways in which we can increase capacity in primary care. And so I think, we've heard both kind of the reduction of the administrative burden, so that will help to free up time for family doctors to spend with our patients directly. But we also know that team-based care is going to be a really important way to build capacity across the system. And I think it's also important for us to touch on kind of that idea of when family doctors are doing that 19 or more hours per week, we know that is a significant factor that contributes to burnout. And we've seen burnout rates amongst family physicians more than double since the onset of the pandemic. So I think we need to think about how do we increase capacity, but how do we also think about this from a recruitment and retention standpoint in family medicine?
Thank you very much. And I'm going to ask Dr. David Barber to chime out on the issue of physician burnout. As leader of the section group on family practice for the OMA, what are you hearing from family physicians about this issue?
Yeah, burnout is a significant issue for our members. And a lot of it is administrative burden. It's really from I think a lack of support. It's the moral injury that Dr. Park talked about not being able to help patients. And the result of it, I know personally more than a few doctors that have just given up and are going to do something else, which is really sad. The reality is practicing family medicine should be one of the best jobs out there, right? The ability to connect with people and to help people, is amazing. The unfortunate thing is, over the last, decade, there's been a lot of shifts and have made that the work less enjoyable and more burdensome, and so here we are in this crisis. I think making the work more enjoyable is so important, and I think that's whatever changes, whatever resources are given to us, that has to be one of the goals, so that we can keep a strong family doctor workforce in Ontario.
Thank you. And Dr. Premji, would you like to add your thoughts on the issue of physician burnout?
Sure. So I think that what we are seeing is exactly what my colleagues have discussed. We're seeing the result of inadequate support resulting in burnout amongst family physicians. And we do think that this is underlying the shifts away from comprehensive family practice that we are seeing. It is much simpler to practice in a focused scope of practice. I don't mean simpler as in the complexity of the medicine or the complexity of the patients, but with respect to those system level inefficiencies. It is much more streamlined a process of care to practice in a narrowed scope of practice right now than in comprehensive family medicine. And we think that this issue of burnout in comprehensive care is underlying at least part of what we're seeing in the shift away from comprehensive care into focused scopes of practice.
Thank you. And some thoughts on physician burnout. Dr. Kumanan, as president of the OCFP, what have you been hearing?
Thank you. So certainly I think I would agree with all of my colleagues that we are seeing very high rates of burnout amongst family physicians. And I think we all know that our work has changed over the last many years, where we are seeing patients who are presenting with more complex medical issues. We're dealing with an aging population. But what I think is really important to touch on is, like, family doctors do love what we do. We love building relationships with our patients and caring for them, caring for their families. Really, I think it's all of the things that get in the way of us being able to do that important work. So the administrative burden, not having the right supports in place. So I think it's a really critical time for us to look at how do we sort of remove those barriers that are getting in the way of us doing what we love to do, and how can we give family physicians more time so we can then spend that time with our patients rather than behind a computer screen or dealing with paperwork.
Thank you very much. And a question now for Dr. Park. What's your reaction to other professions being granted further diagnostic powers in their practice?
Yeah, so the issue around scope expansion, we have a term for that also. We call it scope creep, because as doctors, we are performing innumerable jobs across different spans of health professionals. And the challenge with that is it takes away from our ability to do our core responsibilities. So, with expanded scope, I have tremendous respect for pharmacists and nurse practitioners and other allied health professionals. But I think where it creates some problems is that there's further fragmenting of our system. And this is where our expertise lies, and we want to be able to really advocate for a system that allows the appropriate players in the right places to make the right decisions on patient care. And adding parallel streams of care is non-efficient or cost-effective or patient-centric approach to preventative care, long-term longitudinal care, as Dr. Premji has talked about. And I think that this creates further silos in our system rather than integrating us as a group of professionals that are able to provide care in the most effective fashion.
Thank you very much for that answer. And Dr. David Barber, did you want to weigh in on that issue?
Yeah, the scope expansion, I can see, the attractiveness of bringing other people in. The problem is, is that, we were not consulted. Family doctors, family medicine, the SGFP, we were not consulted when these decisions were being made about the scope increase. And so, what has happened is like Dr. Park said, has been a fragmentation of care, right? Because, the pharmacists, as an example, are not part of our teams, and so we don't, really know what's going on when they go to the pharmacist all the time. And so we know the importance of continuity of, of patients seeing, stable, primary care team. But I think, I really wish, the government had consulted us, and we could have, done things a lot better. That we need that coordination, and we need to talk, so that we can, create a system that's best for our patients. But right now that, that piece actually is added to the burnout, because we're getting a lot more paperwork because of that decision. And so it's a vicious cycle.
Thank you very much for that answer. And I wanted to go back to a point that Dr. Premji raised earlier about less medical students now choosing family medicine. So I'll ask all the panelists to weigh in on this one, but perhaps Dr. Premji, we could start with you. How can we make family medicine more attractive for young medical students and young doctors? And what's one piece of encouraging advice that you might give them?
So we actually do have research that helps us understand what graduating medical students and family medicine residents are looking for when they go out into practice. Specifically out of BC and Ontario, as well as other provinces, we see that graduating family medicine residents are looking for two things. One is support amongst colleagues in their practice. So the majority want to join a group practice where they are working with physician colleagues to share the care of their patients. And they are also looking for an interprofessional team. The majority want to practice in an interprofessional team. This is not surprising given the complexity of medicine and the complexity of our patients. As Dr. Kumanan mentioned, we have very solid data underlying both of those trends in our aging population. And so we know that this is something that family medicine residents are aware of and are looking to have support with. And then the other thing that they're looking for is income stability. So again, survey data has confirmed that they are not interested in the traditional fee-for-service payment model, which is where your income depends on the volume of patients that you see in a given day. Rather, they're looking for these alternate payment mechanisms, such as capitation-based payment, where you're paid a certain amount per year to manage all of the care for each patient. These are the types of payment models that give graduating medical students the income stability they need, especially when you consider that almost half are graduating with medical school debts of over $100,000, in addition to the debt that they're graduating with from their undergraduate degrees. So to make family medicine more attractive, I think we need these two things: interprofessional and family physician colleague support in terms of the practice environment, and the income stability that comes with these newer payment models that have unfortunately been restricted over the last 10 years.
And Dr. Kumanan, do you have thoughts on how to make family medicine more attractive or advice for young doctors?
I think I would start by saying it truly is an amazing profession, and I think all of us feel really privileged to be family physicians. I do feel hopeful. I mean, we are all here today and we are able to articulate very clearly what the solutions are that are required to address this crisis. And I know that we will continue to collaborate as organizations to advocate for those solutions to be implemented. So really, I think it's an amazing profession, and we need to address the challenges that we're facing in the system right now.
And Dr. Barber, do you have thoughts on making family medicine more attractive for medical students or advice?
Right. I mean, the reality is every medical student at some point during their 4 years of training will end up with a family doctor in their offices to see patients and as part of their training. The reality is, because family doctors, are quite stressed and burned out, they're not encouraging medical students to go into family medicine, right? If the medical students are seeing these family doctors stressed and burned out, well, they're saying to themselves, why would I ever do that profession? This person doesn't seem happy, right? So, it goes back to, that's part of the knock-on effect of the state of the current system, right? So if we can add more supports, make the work more enjoyable, take better care of patients, then that's going to flow down to the medical students, and they can see they can make an impact. I mean, the work that's done in family medicine I think has the greatest impact on the health of patients. But things just need to change.
Thank you. And a reminder to journalists that you can put questions in the Q&A chat now, or you can follow up with us later at media@oma.org. We also will be hosting a separate media briefing on November 1st about healthcare solutions for Northern Ontario. On that note, a question for Dr. Park now. Dr. Park, can you explain why the doctor shortage is worse in Northern and rural Ontario?
Yeah, absolutely. A high percentage, I can't remember off the top of my head, I think 80% lives within a few-hour drive of our border with the United States. So we have high concentrations of our population in fairly urban centers, and then a massive expanse in Northern Ontario that has some geographic challenges to living and practicing medicine. And so that is added to the challenge of recruitment, retention of physicians, as well as providing locum support, which I think of as excuse the sports analogy, but bench depth in order to allow people to have the flexibility to work under terms that they want to work. And so there's an inordinate amount of burden on those physicians up in the north. I've heard physicians talk about having two clinics that they have to travel back and forth from that are hours apart from one another. And if you imagine your work environment where you have to drive between one office to the other office, that is 4 hours, and then treat another 30 patients in that day, that's extraordinarily challenging. And that creates some issues. The Northern Ontario School of Medicine has been a massive blessing for the North, providing an influx of human resources, of physicians into that area. But we still really need to do more to continue to highlight the issue and help to provide solutions for Northern Ontario.
Thank you very much. And you mentioned locum support. Can you explain for those who might not be familiar with the term exactly what a locum is and why locum support is so needed in northern and rural communities?
Yeah, locum support is kind of like thinking of a substitute teacher. If you're not able to go to work that day for an illness, there's the ability for someone to come in and help support you in that role. And when we're struggling with our human resource challenges, having that additional support is extremely important. We do it for emergency departments in rural areas where physicians can come in to help support the local communities, and that creates a degree of flexibility for these physicians that are oftentimes working 24/7 in their communities. They're the only physician available, and so giving that physician a bit of a reprieve is extremely important, and can also help extend the career of physicians to have a break, which is not an unreasonable ask.
Thank you very much. And a follow-up question from Marjo John from the Medical Post for Dr. David Barber. Dr. Barber, earlier you were talking about other healthcare professionals and making diagnoses and the need for better coordination. So what would better coordination look like, for example, with pharmacists?
Well, one thing, the reality is that, like I said, what's happening right now is increased fragmentation. So as an example, really the pharmacist, should be embedded in some way into the team, right? Where you can discuss things. I'm fortunate enough to be part of a team, and we have a pharmacist on our team that, we consult with frequently. And so there's no fragmentation of care for the patient. The other piece is, there was no thought given to the communication between the pharmacists and family doctors. So right now we literally, it is a fax. Like we get a paper fax from the pharmacist, and they're all different from all the different, there's no standardization. So we don't really know where to look at things exactly what's happened. And so, that just makes our lives more difficult. And a lot of times I think it actually does not help patients. But it could be done in a way. I mean, we need to collaborate. We need to bring more people in so that we can provide better care. But we just need to communicate better. This should have been thought out better rather than just a unilateral decision. That's what I think.
Thank you very much. And as we mentioned, the OMA is leading a group of about 100 physicians to Queen's Park on Monday to talk about these healthcare solutions that we've outlined today. We do have a question from Megan Ballo with the Kingston Wing about specifically Kingston area physicians traveling to Queen's Park Day. Thank you, Megan. We're going to follow up with you after this media briefing to discuss. And thank you very much to all the reporters who attended today and to ask questions. Thank you to our panelists. We're going to turn it back over to OMA President Dr. Andrew Park, who has some closing remarks.
Yeah, thank you for that. And thank you to our panelists, as well as journalists and members that are attending today. I'll just make a quick closing comment around the idea that physicians really do love their job. And this is really about respecting their autonomy and allowing doctors to be doctors to provide the best care that we can for Ontarians. If there are questions that we didn't get to, the media team will follow up with you. You can also email media@oma.org with requests for interviews or information. We will have a recording of this session available later this afternoon. And again, once again, thank you to our panelists and thank you to media for attending. Take care, everyone.